let me start by thanking all the organizers for inviting me. Very happy to be here in Montreal to talk about causes and consequences of life expectancy inequality. And if you have any questions, please don't hesitate to interrupt me at any time. So this paper is motivated by one simple fact, namely the strong relationship between income and life expectancy. So to give you some statistics, in the United States, if you compare the richest and poorest 25% of Americans at age 40, the richest 25% can expect to live about 7 years longer than the poorest 25%. So this is just the interquartile range. If you look at the very top 1% versus the very bottom 1%, you're talking about a life expectancy difference of 12, 14 years. Similar, qualitatively similar facts have been documented for other countries, including Canada, although the magnitude, of course, differs across countries. So motivated by this one fact, I'm going to ask two questions in this paper. First, how can policies be designed to reduce differences in life expectancy across income groups without lowering average life expectancy? And secondly, what are the consequences of these policies for welfare and the macroeconomy? So to answer these questions, I'm going to do the following in this paper. I'm going to develop a structural life cycle model with incomplete markets, heterogeneous agents, and endogenous health. So in the model, health will affect the individual's mortality risk, medical expenditure risk, and labor earnings. And health, in turn, is endogenous. So agents can affect their health transition probabilities by choosing a healthier but more expensive consumption basket. So the endogeneity of health is coming from basically what you eat. I'm then going to apply this model after I've calibrated it to match, to study the effects of different policy reforms. I'm going to look at the effect of some health insurance reforms and income tax reforms. I'm going to look at the implications for average life expectancy and life expectancy inequality, and their implications for welfare and the macroeconomy. So, what's my data and calibration strategy? So I need a model where health is going to play a key role. And since I want to have endogenous health through basically diets, I'm going to build on medical literature which shows what type of health implications various diets or various consumptions will have. So I'm going to start by getting micro-level panel data on different health indicators, which I will use to construct a Frailty index, which is an objective measure of health that has been widely used in the gerontology literature. This was only recently done in a paper by Karen Hosseini and Kai Tsao. So this is contemporaneous work with what they've been working on for a few years. I'm going to show you how frailty affects mortality risk, medical expenditure risk, and earnings. And if I have time, I'll show you how frailty co-varies with socioeconomic status, such as income, education, and wealth. Then I'm going to calibrate my model to match observed heterogeneity in health by income. But the problem I'm facing here is that the health transition probabilities in the model depends on your consumption basket. However, I don't observe consumption in the data, so I can't estimate health transition probabilities as a function of consumption directly from the data. But what I do observe in the data is income. And I know that income, even conditional on health today, is predictive of health tomorrow. So what I'm going to do is I'm going to apply an indirect inference procedure where I'll be calibrating the health transition probabilities such that the model matches the relationship between income today and health tomorrow, where the mechanism goes from income today, which facilitates higher consumption of healthy goods, thereby transitioning into better health tomorrow. So the causality in the model runs from income to healthy consumption to health transition tomorrow. Yes?
So by healthy goods, you're not just thinking about what you eat, I'm assuming, but also gym membership.
Yeah, so this, exactly. So I'm going to think about it in a monetary way, but yeah, it could be, for example, purchasing a gym membership, exactly.
But it might really matter for a policy point of view, whether you're subsidizing organic food, for example. I know you're not doing subsidies, but still. Subsidizing organic food or, making gym memberships, much easier to get.
Absolutely.
Yeah.
No, I mean, there's ample evidence that, I mean, there are pecuniary investments in health and there are time investments in health. I'm only focusing now on the pecuniary side. A more elaborate version of my model, you could take part of your time endowment that you can allocate that to, for example, going to the gym type of thing, and then you can subsidize that. So it's not directly accounted for in my model, but the purchase of, for example, that gym membership would be counted. So in my model, there's going to be a feedback loop between income and health. So your health will affect your income by affecting your labor productivity and also your disutility of working. So I'll show you data on if you're in very poor health, you have a much lower labor force participation rate. But there's also this part where income indirectly affects health by facilitating healthier consumption. So because of this feedback effect, it means that redistribution of income from, for example, higher income to lower income individuals can affect the health, the distribution of health in the population, because it can affect the extent to which lower income individuals can basically invest in their health through healthy consumption. So because of this feedback loop then, I'm going to focus on policies that redistribute resources from higher income to lower income. First, I'm going to do it through health insurance reforms, which will basically take care of your healthcare expenses. So that's one way you can affect the resource you have available. And then I'm going to do it more directly through changing the level of progressivity of the tax function. And of course, you can also just do subsidies of healthy foods, etc. The reason why I haven't done that particular experience yet is that my consumption basket is still too crude. So I don't think I would do much justice to a subsidy policy right now, but that would obviously be also one way you can study. So we're going to look at a universal health insurance reform, which is going to be a Medicaid for all reform in our model, in my model. So it'll be that the government basically provides Medicaid to the entire population. And what I'm going to show you is that such a reform will lead to higher average life expectancy, a slight increase, and lower life expectancy inequality. But it also has good implications for the macroeconomy. So it leads to lower healthcare spending because of the improvements in the population's health. It leads to slightly higher GDP per capita because, again, improvements in health facilitate higher labor supply. And it's going to lead to slightly higher steady state welfare. So if individuals had to choose behind the veil of ignorance, they would prefer, in my model, to be born in a world with universal health insurance. If you take the transition into account, that is, of course, not going to be the case. But if you just do the comparison of steady states, yes?
Of course, there are incomplete markets here, right? I'm
Yeah.
wondering, in the health investment directly, right? Is there an inefficiency here, or are people constrained in the benchmark in terms of their health investment?
No, so it's very concave. So there's room to improve the probability of transitioning into better or worse health, but it's an incredibly concave function. So even if you're Bill Gates, you won't be able to get into perfect health with certainty in this case. But the agents will perfectly know the health transition probabilities. They will know the implications of every choice they will make. The trade-off in this model is going to be that healthier goods are going to be more expensive, motivated by the data. So lower income individuals then face a trade-off between higher current period consumption and worse next period expected health. So higher income individuals will be more willing to sacrifice on current period consumption to end up with better health transitions for tomorrow, because that's the only way to extend our lifetime. I think there was another question. Yes.
So if I understand correctly, since you cannot actually invest in your health directly, that's the consumption basket.
Yeah.
So your investment, going to the doctor, doesn't become cheaper, it doesn't appear somewhere in the model?
No, so the healthcare expenses or medical expenses will be completely exogenous, only a function of your health. Of course, when I'm doing a universal health insurance reform, I am really constraining the effect of such a reform, because you would also expect on, for example, research by a lot of people in this room, that an expansion of healthcare or health insurance would also facilitate higher healthcare spending, which might also improve health. That is not in the model.
So this effect is only because individuals have a higher disposable income.
Exactly. It is all about affecting your budget constraint.
So the income elasticity matters here for your consumption basket, because if the only thing that changes with respect to medical spending is the you have moral hazard, because then individuals will care less about that spending, so like they have less incentive. So the income elasticity will be very high.
Yeah, no, so it's I can't remember the number exactly on top of my head, but it's within estimates of what they found in the micro literature. So the model is going to be calibrated to match all of those micro estimates. Was there another question? So yeah, that's the universal health insurance reform. Then we're going to do two other reforms. I'm going to do an expansion only of Medicaid, which provides health insurance to low-income individuals. And I'm going to change the tax code, so by making it more progressive. And again, I find that both of those reforms, which again redistributes resources to lower-income individuals, will lead to a slight increase in average life expectancy and a slight reduction in life expectancy inequality, but they will have negative implications for the macroeconomy because they're distorting labor supply decisions. So the reason why this is kind of interesting, that the universal health insurance will not have the same distortionary effect when it comes to labor supply, is that there is no income test under universal health insurance. So you don't have this incentive of reducing your labor supply exactly below a cutoff to become eligible for Medicaid. So the eligibility criteria for Medicaid creates a lot of distortions exactly around the margin. So the higher that margin, of course, the higher and higher income individuals might choose to go away from private insurance to instead try to be eligible for Medicaid. That particular margin is not present under universal health insurance. So what's the related literature? Sorry.
It's cheaper, is it meant to pair both? Wouldn't expand Medicaid much cheaper?
Yeah, no. So I'm going to show you, of course, the public finance implications. Only expanding Medicaid is going to require an increase in the average income tax rate of maybe 2 percentage points. If you want to go all the way to universal health insurance, we're talking about 4, 5, 6 percentage point average increase. So that will be accounted for in terms of the macroeconomic implications. It will be distortionary. But if you do this steady state analysis, sort of the benefits of it outweighs the distortions. So what's the related literature? So the first literature I'm related to is the empirical literature that studies the relationship between socioeconomic status and longevity. I'm not contributing at all. This is basically just empirical facts that I'm basing my paper on. So a lot of the statistics by Angus Deaton, of course, and Paxson, also Chetty et al. So similar studies have been done in Canada by Milligan and Sherrill. My paper is mostly related to the life cycle, to the structural macro literature that includes health shocks in life cycle models. And in particular, it is related to a subset of that literature that endogenizes the evolution of health. So Raquel Fonseca's paper and co-authors here. A lot of papers have been written in this literature where we're endogenizing health. To my knowledge, I'm the first paper to endogenize health through the choice of the consumption basket that is healthy versus unhealthy. So the particular mechanism I have in mind is related to medical literature on health implications of diet. I'm just going to call it diet, so don't necessarily think about it going on a diet, but just in terms of what you eat. So there are numerous studies on the health implications for like consumption and how it relates to cancer, cardiovascular disease, etc. All of these components will be included in my health measure. So there's like medical literature to build on the causality here. So let me first show you some data. So I'm going to study the dynamics and implications of health in the data. And to do that, I'm going to start by getting some micro-level panel data on health indicators, income, wealth, medical spending, and demographics from 2 data sources that have been extensively used: the Medical Expenditure Panel Survey and the Health and Retirement Study. Then I'm going to use the health indicators to construct a Frailty Index, which is an objective measure of health. And I'm going to show you that higher frailty is associated with higher mortality risk, higher medical expenditure risk, and lower labor earnings, and that frailty co-varies negatively with socioeconomic status. Some of these facts have also been documented, as I mentioned, in contemporaneous work by Hosseini and co-authors. So how do I construct the Frailty Index? The Frailty Index is a count of how many diseases and disabilities a person has. So I'm going to follow standard methodology in the gerontology literature on how to construct this index. So I'm going to include diseases such as whether or not you have cancer, whether or not you have high blood pressure, diabetes, etc. I'm going to include variables that measure if you have activities of daily living, This can be difficulty walking, difficulty dressing, taking a bath. I'm going to include variables that measure if you have instrumental activities of daily living. This can be difficulty taking medications, difficulty paying bills. And I'm going to include some variables on cognitive impairments. Then I'm simply going to sum all of these diseases and disabilities. I'm normalizing the index from 0 to 1. So value 1 means you have every disease and disability. I think I have 32 variables in here. If you have 0, you have basically the perfect objective health. So I'm going to do an equal weighted one. You can do principal component analysis, a weighted one. So Karen Kopecky and our co-authors, they were doing a lot of these things, and basically it doesn't matter. What really matters is the sheer number of diseases and disabilities you have. Somebody who has 5, 10 of these, maybe 15 of these, doesn't really matter how you weight them. You usually end up with people that those will be very sick no matter how you choose to weight these different components. So on the left here now, I'm showing the frailty distribution by age. So as you can see, average frailty is increasing over the life cycle. People are getting sicker or objectively in worse health as they age, going from a score of about 0.05 up to almost 0.4 by the age of 85. But also the standard deviation is also increasing over time, so the dispersion of frailty is also increasing with age. And on the right here, I'm just showing some frailty percentiles. So P25, that's the healthiest 25% given an age, and P75, those are the sickest 25% given an age. And if you just draw a line here now straight over, you see that the sickest 25% of 20-year-olds have the same objective health as the healthiest 25% of 50, 55-year-olds. So what that would mean is that if you take this as an objective measure of health, the sickest 25% of 20-year-olds are in the same shape as somebody who is 30 years older and in the healthiest 25%. So these are, and I'm going to show you, these are going to have major implications for a lot of factors. Yes?
Just to clarify, when you're looking at activities such as difficulty walking and dressing,
Yeah.
usually these are scales, right? So how do you choose to tackle? Is it any difficulty or?
Yeah, so some of the, it's a great question. Some of the variables like on the diseases, like do you or do you not have cancer, or have you not been diagnosed with cancer? For some of these, as you mentioned, it will be on a 0-1 index. Some of them will be 0, 0.5 to 1 if it's a 3-point scale. I'm just then taking an equally spaced grid, basically. So if it's 3-point scale, it will be 0, 0.5 to 1. If it's 5-point scale, it's 0, 0.2, 0.4, etc. So again, that also matters since maybe a score of 0.8 is very different from a score of 0.2. I would not be able to account for that, but based on that paper I mentioned to you, they've done a lot more analysis on these things, and they basically find that it doesn't really play a big role.
You saying it's a reporting task, so respondents were asked about their objective health?
Yeah.
So how much does it matter, for instance, for people like around 75, 80 years old who might be cognitively impaired?
Yeah, so this one is, that's a tricky one. If you remove it, you will have a slight reduction in mean and slight reduction in standard deviation among the very, very oldest.
If you remove the cognitive impairment.
Exactly. But most people seem to be able to judge their own activities of daily living, the instrumental activities of daily living. The cognitive impairment ones is probably the only one that is a little bit questionable. But this is a household level study. So first of all, there's no one in a nursing home, so no institutionalized individuals will be part of the data. And since it's a household level study, if you're in great shape, but the one you're living with has Alzheimer's, for example, you will most likely be the one who fills out the survey for both of you.
Okay.
So it will have to be a case where either you're alone with certain cognitive impairments that makes it very difficult for you to fill this out, but again, of course there's going to be measurement error. But if you can do this with the health and retirement study, medical expenditure panel survey, PSID, etc., the numbers are almost perfectly aligned. So it doesn't seem like measurement issue is a major issue.
There is some research coming from USD that they are looking at response in surveys as a way to predict cognitive impairment. people are like rapid guessing or leaving questions blank in previous surveys as a predictor of Alzheimer.
I see.
So you might want to check it out.
That's a great point. Yeah, I'll talk to you about that afterwards. I did not know it. Thank you. So what I'm going to show in the next 3 slides is that frailty has large implications for mortality risk, medical expenditure risk, and labor market outcomes. So to estimate mortality probabilities, I'm just going to fit a logistic regression that accounts for age, frailty, and higher order moments in the 2. So what I'm showing here are predicted 1-year mortality rates by age and frailty quartile. And the reason why it's a little jagged is just I'm taking average frailty, for example, of individuals of a given age in the 4th frailty quartile. So what you see here now, if you take 85-year-olds, individuals, the healthiest 85-year-olds have a 1-year mortality probability of, 5, 6, 7%. If you look at the sickest 25%, they have a 1-year mortality probability of nearly 20%. So it shows that as frailty gets very high, there is very high mortality risk associated with it. And it's true across all age groups, or of course, like this goes up over time. So you could do the same thing with self-rated health or other measures of health, but it basically shows that it's at least predictive of mortality. And again, remember, these are most likely downward biased estimates because we're not including anyone who's institutionalized. So the absolutely sickest people might also then be in nursing homes. They might actually be increasing some of these numbers even more. Here we have the implications for medical expenditure risk. So in this table, I'm showing average total medical spending by age and frailty percentiles in constant 2009 dollars, where medical spending now includes all the costs covered by private insurance, public insurance, and out-of-pocket. But it's not what is not included here is the cost of buying insurance. So these are basically purely your healthcare costs. These numbers you can basically take as given. So what the Medical Expenditure Panel Survey does is that when it comes to healthcare utilization, it is corrected by basically hospitals. So if I say that I'm spending, $200, that survey is designed to keep track of healthcare spending. So they will actually go in and correct that. Oh, actually, they got spent $1,000. So those numbers are correct. It doesn't necessarily mean that the reporting on cognitive impairments, etc., is correct, but the medical spending parts are correct. So what I show you here is that if you take 20 to 64-year-olds, individuals in the first frailty quartile spend about $1,200 per year on healthcare, so roughly $100 per month. If you look in the sickest 25%, they spend almost $10,000 per year. If you look at the top 5% of them, the numbers get as high as more than 18,000. Get qualitatively the same picture for people that are over 65, but of course, average medical spending just increases across the board. So what I want you to take from this table is that higher frailty is associated with significantly higher healthcare or medical expenditure risk. Lastly, let's look at some implications for labor market outcomes. So in the model, frailty will have 3 implications for labor market outcomes. It will affect your labor productivity, so think about it as your hourly wage. It can affect how many hours you would like to work, and it can affect your labor force participation margin. So what are then the numbers in the data? Well, if you take 25 to 64-year-olds that work at least 10 hours per week, and you basically regress log wages on frailty and other components, you find a semi-elasticity of hourly wages with respect to frailty of -0.4. So it's not a big effect because frailty doesn't increase that much over the life cycle. So what this suggests is that maybe frailty doesn't have much implications for income. However, where frailty really matters is basically the 0-1 variable on whether or not you're even participating in the labor force. So this is what I'm showing here. These are labor force participation rates by age and frailty. So ignore the very youngest ones because a lot of them are in school. But you can see if you're in the first, second, or third frailty quartile, your labor force participation rate is pretty much exactly the same. But notice here now, what if you're in the 4th frailty quartile? So take, for example, a 50-year-old. Somebody in the 4th frailty quartile will have maybe a 30 percentage point lower labor force participation rate than the rest of than other 50-year-olds. So what it shows is that as people get sufficiently sick, it is really limiting their ability to work. So a lot of these can go on disability, etc. But so you're not talking about like the top 1% here now. You can see this is 25% of individuals given an age. So if your health deteriorates sufficiently, the main impact it will have on your income is your ability to even enter or participate in the workforce. And of course, this will also have long-term implications because it will affect your social security contributions and therefore affect your pensions even when you're older. So what I'm going to do, yeah, sorry.
This is MEPS.
This is MEPS, exactly.
It is the reason that you don't use case ID because you can use a Frailty in the case ID.
Yeah, no, so Karen and Jackie and Roosbeck did that in their paper. Again, the labor force participation margin is actually almost identical. So that doesn't make a difference. So yeah, since they did it, I didn't do it. So I wanted to have slightly different graphs from them. This is something I started when I was still in Minnesota, and they had just started working on it themselves. So we sort of ended up on like two diverging paths. So, but yeah, for that particular graph, if you do it in PSID, it's virtually identical. Yes.
The type of like careers different for the people in this like forced frailty.
One more time. Sorry, I didn't hear the start of your sentence.
The type of careers quite different for the people in this like forced frailty quartile. Like they have more manual jobs that are more physically demanding. So if you like the interaction between kind of frailty and the type of job these people would like to have, and
that's a great question. I haven't looked too much into the occupations of them, but I do have data on it in the MEPS. So they have industry codes and occupation codes. So I can take a look at it and see if the sample is large enough to see if there are, most likely you'll see some effects, yes.
Presumably these people are less educated.
Yeah, no, absolutely. So higher education are less frail than lower education, so that's part of it. But yeah, even within an educational group, you might be right that you're going to see also differences in occupations.
So you have data on the dynamics, like how long this effect is lasting. Like I may drop out, but the labor market.
So you mean like the persistence? You mean, yes. Or? So that's a good question. I don't know on top of my head. So for the MEPSR now, I do observe you over 2 years. So I could see conditional on your frailty improving, which is unlikely. Unfortunately, it really is declining all the time. But conditional on it having improved, are you not re-entering the labor force? I haven't looked at that number, but I'll make sure to take a look at it. So I don't know. My guess is that it's almost like a death spiral, that once you reach, like after age 50, for example, my guess is that they're going to be permanently disabled. And my guess is very few of them will be able to re-enter the labor force. But that's just speculation. Yes?
So your story is going to be about lifestyle, right? Are you going to tell us something about how much frailty is due to lifestyle versus accidents, diseases, whatever that you might randomly get independently of the lifestyle?
So yeah, so the way I'm going to estimate my frailty transition matrix is that everything that income predicts for next period of frailty, I will attribute to healthy consumption, conditional on your current health, current age, and educational attainment. So education will play 2 roles in the model, both a direct one in the production function, and also, of course, they're going to have higher income on average. But I'm going to attribute everything to income after I've controlled for your current health.
Okay, because there was this point about like different kinds of careers, so right, which affect your income and maybe also affect your frailty transition. So the idea is that education would capture that. Yeah, I mean, it's would definitely take up some of it, but I'm sure that it's not doing perfect diligence to it. But yeah. Education would also help me with, I mean, there are numerous reasons why educated individuals will be in better health than lower educated individuals, and part of it is smoking, for example, one of the lifestyle choices that will be in the reduced form way capture my essence. I'll get there in a second. So what I'm going to do now, oh, sorry.
Is it the case that the first 3 quartiles are very close to each other?
Yeah, this is sort of always the case. Maybe a little bit, except for medical spending goes up a little bit, but it really does seem to show that, and it's not even just the top quartile, it's more like the top quintile, I've noticed. So it's like if once you reach the
the bottom 20% on the health spectrum, that's when really things start compounding. So I'm not saying that people shouldn't worry about their health if they're in the bottom 75%, but it really seems to show that it really picks up in order to get closer to the tails. So what I'm going to do now, I'm going to set up a model that can account for these facts, and I'm then going to use that model to study some counterfactuals. So let me first give you the environment. So there are going to be consumers, the government, health insurance companies, and firms in the model. So the consumers will face medical expenditure shocks, labor productivity shocks, and frailty shocks. They will consume a generic good, a healthy good. They will supply labor. They will choose how much to save, and they will choose whether or not to purchase private health insurance. There's going to be a government that provides health care or health insurance in the form of Medicare and Medicaid. It's also going to run a social security program. And I need a welfare program in the model that provides minimum consumption, and it's because I have non-discretionary medical expenses. So it's just a coding feature. Some people might have negative consumption because their medical expenditure shock is so high that there's no way for them to pay for it. This is not going to be binding for a lot of people, but it's basically, think about it as a food stamps type of program in the model. I'm going to finance all of this through a progressive income tax. Yes?
I'm sorry, I think maybe you said it, but I missed it. So are you going to, in the frailty shocks, are you going to model that depending on your occupation, you might be more at risk on job and then incur more, you may have more job accidents? I mean, being a worker and being a university professor, that's not entail the same risk. And so are you going?
So I'm not going to have occupations, but I will have education. So you're going to see in 2 slides how education enters the health transition probability. And education will also have a deterministic effect on your income. So think about it as educated individuals will have higher average income than non-educated individuals, and they will have more favorable health transition probabilities than non-educated.
Yes, so this is what you said. So it's, it's embodied in this.
Exactly.
In that mechanism. Okay.
But it's not going more granular, and I'm very sympathetic to that, and I think you guys are right, but there's no occupations, only education.
Yeah,
okay. I guess one could think about how that matters, how gender would matter for that, because women are going to be more educated. They're also, on average, healthier and have higher life expectancy.
So that's interesting. Women have longer life expectancy, but they have higher frailty, and that is not easy to say why, because this is supposed to be an objective health measure. So it could be that they are just more pessimistic and rating their own health worse, but since they are living longer, or there's something else going on here. But it's yeah. So women, that's sort of an interesting fact: higher frailty, but higher life expectancy at the same time. I'm going to have one generic gender, so there won't be also be gender in here. You could do this entire analysis, of course, just on the subset of the population. It will be a cleaner study. So there's going to be health insurance in the form of private health insurance and employer-provided health insurance. And then we're going to have some firms that will just hire capital and labor to produce. So the consumers are going to be heterogeneous along many dimensions. So they're heterogeneous in their age, frailty, assets, stochastic labor productivity, medical expenditure shock, health insurance status, and educational attainment. They all enter the economy at age 20, and as I mentioned, they're going to be either college educated or non-college educated, and that will be fixed and permanent over their life cycle. They will consume a generic good C, a healthy good CH, and they will choose how much labor to supply. And I'm going to be assuming that generic and healthy goods are perfect substitutes in utility. So I'm perfectly indifferent between eating healthy and eating a generic good. However, the healthy good is more expensive, but also leads to lower next period expected frailty. So this is sort of the, so this is loading everything on the healthy side. So a richer individual will then be more able to sacrifice current period consumption and instead go into a healthier, more expensive good to get into better frailty tomorrow. A lower income individual will be less able to do so. A more elaborate version of the model will have 3 types of goods, like a generic good, a healthy good, and an unhealthy good. The unhealthy good is something I'm currently working on. So unhealthy good being smoking, being basically the negative of this one. it is difficult to rationalize unhealthy consumption unless you have like differences in preferences, etc. So that's why I don't currently have it. So yeah, here, think about it as the main mechanism is now going to go from, since the healthy good is more expensive, the only reason why the richer people now are going to be able to live longer in my model is because they have more able to consume the healthy good.
And if you wanted to have more of an intergenerational link, then I guess I would put in habit formation.
Yep.
Because, unfortunately, it's not true that people are indifferent and it's not differences in preferences per se.
No.
It's difference in what you ate when you were a kid. And then just a last comment on the gender and education, that's going to understate the relationship between frailty and education.
Yep.
For our college people, but overstate the relationship between frailty and education for the less educated people.
No, you're right.
You're just having the different mix of genders.
No, you're right. So the habit stuff is interesting. I'm working on another paper, which is I've got access to a lot of data, so we can actually test habit formation over the life cycle. So it's like a follow-up paper on this one. It's going to have all of that built in. So I'm not sure if I can click any links. Can I? I can. Well, okay. Then you just have to trust me. There is a relationship between consumption and health in the data. So just taken straight from the medical literature. The reason, again, why I'm focusing on healthy consumption and frailty is because frailty is composed of, let's say, do you have obesity? Do you have diabetes? Do you have cardiovascular disease, etc.? And consumption has been shown causally to affect all of these different components. So if you do, for example, self-rated health, it will be more problematic because I might feel better for eating unhealthy. So I don't want to have that in my measure. So yeah, the mechanism is sort of grounded in medical literature. Yes?
I'm wondering where individuals are actually constrained. Because, for example, we talk about the healthy basket and what comes to mind is obesity.
Yep.
But it's not only the fast food consumption, it's also the quantity. So they could achieve healthier ways just by reducing their fast food consumption instead of eating 2 burgers in one. So I would expect that this income elasticity would come from the value statistical line, that it's not relaxing the budget constraint that tends individuals consume healthier goods, is that they have a higher incentive because now they want to survive for longer.
Yep. So I mean, the value statistical life will be calibrated in the model to match that. So that's going to affect average investment, basically average healthy consumption, and therefore affect average frailty. So I'm going to have non-homothetic preferences that will be calibrated such that on average you reach the right frailty given age. And then the price difference between the healthy and the generic good will be calibrated to match the life expectancy inequality, conditional on all the other features. So here, finally, the frailty transition probabilities depend on your current frailty, so it's persistent. Depends on your age, it's just deterministically more and more likely to get sick over time. Depends on education, as we mentioned, and it depends on your healthy consumption. So this is where you technically want to have unhealthy consumption as well, will make it a lot more ambitious than what I currently have here. And just like in the data, it will affect survival probability, medical expenditure distribution, and it will affect your deterministic life cycle labor productivity. And all of these I can estimate directly from the data, since I'm measuring frailty in the model and the data exactly the same way. So in terms of health insurance, there's going to be private health insurance and employers' private health insurance. So the consumers can purchase private health insurance for the next period, and I'm going to assume it's actuarially fair given a pool, and a pool is given by people of a particular frailty, particular age, and particular current period medical expenditure. So these 3 variables is sufficient to predict average medical expenditures next period, so you can buy health insurance then at that price. This is a model that is calibrated before the Affordable Care Act. So that's why I'm letting basically insurance companies condition on your frailty. They're allowed to condition on your health and also your current medical spending. There's going to be Medicare in the model. So if you're over 65, you're always going to get Medicare. But Medicare doesn't cover all healthcare expenses. It's like maybe a 25-30% co-insurance rate. So if you want to further reduce your out-of-pocket healthcare expenses when you're old, you can purchase private insurance as complementary insurance. Then we're going to have employer-provided health insurance. So most of the working age population will get health insurance from their employer. And I'm going to follow the same approach as I did in two of my papers with Juan Carlos, Tim, and Gajan. I'm basically going to assume that when you enter the workforce, a share of you guys will be stamped on the forehead saying that you will be working for a company that provides health insurance. You're not allowed to opt out of that. And the rest of you guys have to buy health insurance privately. It's a very simple way of doing it. I have a new paper with Juan Carlos that I presented in Santa Barbara where we're doing a lot more work on that. So this is the simplest possible way. So in this room, roughly half of you will be working for a company that provides health insurance. The rest of you would have to buy it privately. So what the employer will do is just pool all the medical expenses of all its employees and then share those expenses evenly across the workers. So the worker have to pay a cost pi e every period, and in return, a share, 1 minus chi e of their healthcare expenses will be paid for by the firm. All right, finally, a value function. So it looks messy, but it's actually very intuitive. So again, the idiosyncratic state is given by an agent of a particular age, frailty, assets, stochastic labor productivity, medical expenditure status, and health insurance status, and her educational attainment. So what does the agent do? This is a young consumer who does not work for a firm that provides health insurance. So this individual has to choose how much to consume of the generic good and how much to consume of the healthy good. And as you can see, they're perfect substitutes in utility. Choose how much labor to supply, how much to save for next period, and whether or not to purchase private health insurance for the next period. You're discounting the future rate beta. You survive with the frailty and age-specific survival probability. Your frailty tomorrow is endogenous, so its expected value depends on your current frailty, your current age, educational attainment, and your current consumption of healthy good. You have the Markov transition probabilities for the labor productivity shocks and the medical expenditure shocks. And then what about your budget? Well, you choose how much to consume of the generic good. If you want to buy healthy goods, they come at a premium. So the price or the relative price P here now is going to be larger than 1 in equilibrium. You choose how much to save. These are your out-of-pocket healthcare expenses, which depends on your medical expenditure shock and your insurance status. You can buy private health insurance for the next period at this cost. You get your labor earnings if you're working. You have to pay non-linear or progressive taxes. If you're extremely poor, you're going to be eligible for this minimum consumption program in the model. You get your interest and principal on your assets. The B part here now, these are accidental bequests. So some people in this model will die in every period, and they might have some wealth. So I'm just going to take all of that wealth and uniformly distribute it across the population. And then if you're low income and eligible for Medicaid, then a share of your healthcare expenses will be paid for by Medicaid. Then we have your income, you have your out-of-pocket healthcare expenses, and standard non-negativity constraints on the different variables. Any questions about the value function? Yes?
So there's no issues of quality.
Quality of?
Healthcare.
No, it's one platform.
So whatever insurance you have, you get the same quality.
Exactly, yeah. So that will be one of the reasons why I'm going to be underestimating the effect of having health insurance on your health, because it's most likely also going to allow you to get access to better health.
And that has repercussions on the production side.
Absolutely, yeah. Just totally absent in the.
I mean, you may not want to think of the healthy goods as simply an addition to your consumption. You might want it instead of, I mean, the way you have it, it adds on to your consumption basket.
Yep.
And I might want to eat carrots instead of eating, whatever, Fritos.
Yep.
But it's not necessarily true that I eat Fritos plus carrots.
No, I see what you mean. I mean, you're allowed to go to the corner on either of these. You can set Z0.
No, but it's the math. I mean,
yeah.
The way I would write the utility function would be different in that case.
Yeah.
So
no,
I'm trying to think about what's the best way. I mean,
yeah, this is I mean, I agree with you. I would not say I'm perfectly indifferent between these type of goods myself. So yeah, it's probably not the right way of modeling it, but it's sort of it does the trick in the model of having a very simple trade-off by having the perfect substitutes and only having a price difference. But yeah, I understand.
What is the H again?
Capital H.
Yeah.
These are your out-of-pocket healthcare expenses. Okay. So imagine that you face a bill of $1,000. Yeah. Your health insurance pays 80% of them.
Yeah. I understand the way you model it, but I would have made my utility also dependent on the consumption of my health goods, of my spending in health. And I mean, in the beginning, I thought that there would be some kind of maybe recovery, like you would spend some money into health expenditure, and then there would be a possibility to catch back your, not initial health, but you could limit, and this could enter your utility function. It's not the case in your model, right?
No,
because
so
the F is
all of the healthcare bills, think about this as somebody just sends you a check, you have to pay $1,000 this month.
Then,
it is completely exogenous.
Is pure loss.
Exactly. It's pure loss, and it's purely exogenous.
Yeah, and it's only going to enter your utility because it's going to decrease your consumption.
Exactly. Yeah. So this is why a health insurance reform can facilitate higher consumption of healthy goods in this case. Basically, imagine that you eliminate this part, you have more resources available.
Yeah, the purpose of health insurance is only to make you able to consume more.
Exactly, yeah. But that's definitely underestimating the value of insurance in the data because, yeah, I mean, it can affect your utility, it can affect your health transition probabilities in the data. It's just completely absent here. So I have to speed up a little bit. The next two value functions, this is a value function for a consumer who does have employer-sponsored health insurance. It's exactly the same problem. The only difference is you pay your premium for being on basically your employer-sponsored health insurance premium, and in return, a share of your healthcare expenses are covered by your employer. But apart from that, it's exactly the same problem. And similarly, if you're old, if you're more than 65, you're going to get Social Security benefits, which depends on your educational attainment, but you're still allowed to work. So if you want to, like 15-20% of Americans still work after the age of 65. There's going to be a higher disutility of working that's going to go up with age, so very few of them will work in the model, but they can technically have both. And also, you always have access to Medicare, so a share of your healthcare expense will always be covered by Medicare. But apart from that, again, they're solving exactly the same problem. All right, calibration. So we already talked about this. I'm going to have non-homothetic preferences building on building on Hall and Jones. So this B part here now, this is what makes it non-homothetic. This governs the value of life in the model. So the higher the value for B, the more I'm valuing staying alive, and therefore the more incentives I have of investing in healthy goods. Because I'm adding an amount B in every period at which I'm alive. So if you crack up B a lot, then a lot of people will shift their consumption towards the healthier goods. If B goes lower and lower and lower, you have less incentives of investing in healthy goods. So I'm going to be calibrating B here to match average frailty at, I think, age 60, and we'll see in a couple of slides.
So it's being alive that period.
Exactly. So you get the same. This is not a function of health or anything like that, which it probably should be. This is, the assumption is you're going to get a value of B every year you wake up. You get that.
I mean, I might be thinking about this wrong, but why wouldn't it be, wouldn't I give up everything to be alive? I mean, what's the alternative? It's being dead, what's the trick?
It depends on how you normalize that. So I'm normalizing that to 0.
Yeah.
If you normalize that to, let's say, a negative infinity,
yeah.
That's the same as being infinitely risk averse. So you're running into issues there of how people are making their choices. So the outside option, if the outside option is to be dead, you have to either calibrate that value or you have to calibrate the value you get in every period.
I would not do it that way. I think I would put it as, so you want a non-homotheticity, I don't remember why, but you want something non-homothetic. There's many ways to get something to be non-homothetic, and maybe you'd like to think about that what I value is the healthiness of my life and not the value of being alive, because the outside option just doesn't sound very good.
No, so you could let, Raquel, isn't that what you guys did in your paper? So you could let B be a function of F, or a function of health. At that point, basically, it is the quality adjusted life years that I'm really valuing.
Yeah.
Here, that's not present.
But that gives you a different kind of outside option.
Absolutely.
Yeah.
Then you have to take a stand on basically what's every year of being sick is worth X% of every year of being healthy. So I mean, there are estimates of that in the literature.
Yeah,
So
I mean,
that would
myself,
be.
I would think it just would give me.
It wouldn't qualitatively change
you know.
anything in the model, but it might change some of the curvature.
Yeah.
Yes.
So you have a common B. That implies that, let's say, you have high income people and low income people. High income people are going to invest more in health.
Exactly. This is they have a higher. The optimal length of life will be higher for higher income individuals and lower income individuals, and the only way they can achieve that in the model is through higher investment in healthcare. So this is it's built in. I told you we're going to have so this utility of working just calibrated to match the labor force participation rate by frailty and labor force participation rate by age. The social security function is going to be very simple. I'm going to take one from Pancarla's and Dirk's paper. It depends on your educational attainment, but it doesn't depend on your lifetime earnings. So it's everybody with the same education will get the same social security benefits. It means it's a lot more progressive in the model than it is in the data. And the reason is if I have to keep track of lifetime income is another continuous state variable. And you already saw my state space is somewhat crowded, so I didn't want to include the one more. Progressive income taxes, just using the tax function from Gueva and Strauss. You can also use the recent one from Heathcote, Storslat, Mills, Violante. It won't change anything. I'm going to calibrate the labor productivity process to match the earnings distribution the same way that Victor Rios-Rule and his co-authors did in 2003. This is a way, think about it in this way, it's a standard income process where there is what they call a Michael Jordan shock. So there's a really high labor productivity, and that is generating this very right-skewed labor earnings distribution. So it's been used extensively in the literature. All right, some parameters. These are just the parameters that are determined outside the model, so they're all fairly standard. You live until at most age 100, and you enter at age 20, and everybody starts receiving Social Security and Medicare at age 65. All the productivity parameters are all very standard from the literature. The co-insurance rates on the different health insurance programs and the Medicaid eligibility criteria are all straight from the data prior to the Affordable Care Act. Let's look more at what is calibrated. So just pick theta to normalize units in the model such that GDP per capita is equal to 1, just makes everything easier to interpret. Then I'm calibrating a discount factor to match the capital to output ratio. I'm setting the Social Security replacement rates by education to match average Social Security earnings of people with and without a college degree. This constant term in the utility function B is calibrated, as you can see, to match average frailty at age 60, which gives you a value of 6.5, which interestingly is like, I think my estimate was 6.2 in the paper I just published. So using completely different strategies. So it's good to see I'm usually consistent with my own papers. The relative price of healthy good, remember, that governs the trade-off between higher current period consumption and lower next period expected health. So it has to be larger than 1, and I'm calibrating it to match life expectancy differences by income quartile age 40 and give it a value of 1.08. Minimum consumption is set to about $3,500 per year, and the share of people eligible for for employer-sponsored health insurance, and this is calibrated to match the same numbers in the data. And then I have to scale healthcare costs up a little bit to match healthcare spending to GDP. It's a common problem because the Medical Expenditure Panel survey underestimates healthcare expenses since they do not cover institutionalized individuals. And lastly, all the parameters of the labor productivity process will be calibrated to match the earnings distribution. So the Frailty transition probabilities is the only one that is tricky. Because I told you in the beginning, I don't observe consumption in the data, so I can't estimate Frailty transition probabilities as a function of consumption directly from the data. So that's why I need an indirect inference procedure. So what I'm going to do is I'm going to go to the data, and I'm going to assume that frailty is drawn from an ordered logistic process that depends on current frailty, current age, current education, and current income. So income is basically substituted for consumption. Then I'm estimating this process in the data. Then I'm simulating my model, estimating exactly the same regression. And then I'm iterating on the parameters of the frailty transition matrix and the rest of the parameters to match this relationship. So what this means is that the model now generates a relationship between current frailty and income and next period frailty that is consistent with what we observe in the data, where the causality in the model goes from income to consumption of healthy goods to next period frailty. So the causality is what is built in, but the relationship is consistent with what we see in the data. All right, a couple of results. I'm not going to go through any model. Sorry.
The income part, I don't know how to think about it exactly. Are you thinking about it causally? Because the causality could be the inverse, right?
So there is two-way causality both in the model and the data. So because frailty affects income contemporaneously, and income affects frailty next period through consumption today. So that two-way causality is there.
Well, here they do, right? I have savings.
Yeah.
So I could spend out of my wealth.
Absolutely.
So I'm not sure. Okay.
So you'll.
I mean, you might want wealth instead of income. Yeah.
No. So I'm using wealth as a way of seeing if the model matches the data. So you can compare the wealth to frailty distribution, and I'm slightly underestimating it, but this is not targeted, it matches it. So otherwise you could do it as you suggested, and then use income. The problem with wealth is that for lower income individuals, a lot of them are hand to mouth, so it will be tricky. It would basically assume zero consumption.
Yeah.
So let me show you some results. I'm going to do a universal health insurance reform, and I probably have to skip the rest, but this is the most interesting one. So what I'm going to do is I'm expanding Medicaid to the entire population. Medicaid covers 86.2% of healthcare expenses. So what this means is that now the government will cover 86.2% of everyone's healthcare expenses. I'm going to finance that period by period by increasing the average income tax rate in the economy. So if I do that, I get the following. So we have the benchmark model in this column, and we have the model with universal health insurance in the rightmost column. So let's first look at life expectancy. So average life expectancy at age 20 goes up a little bit, from 78.9 to 79 years. Again, remember, health insurance does not affect your health transition probabilities in this model. Health insurance only facilitates higher consumption of healthy goods because it loosens your budget constraint. Most likely, you will end up with an even higher average life expectancy if you, for example, incorporate the features of your model. In Raquel's model, at that point, health insurance is also going to lead to better health transition. So this is most likely a lower bar for how much life expectancy will go up. And also life expectancy differences at age 40 by income quartile goes down. So it reduces life expectancy inequality from 7 years down to 6.6. It's not a big effect. And what that basically suggests is that most of the relationship between income here and life expectancy seems to go from the direct way. So frailty to income, not income to frailty, unless there are other mechanisms at play. But this is at least good news in the sense that universal health insurance will have positive implications for life expectancy and life expectancy inequality, or reduce life expectancy inequality. What about its macroeconomic implications? Well, GDP per capita will go up by 0.5%. That is because of an increase in both labor supply and capital. So where does this come from? Well, health insurance will lead to higher life expectancy, and this can, of course, only come because the population's health distribution improves. People are in better health because they're investing more in healthy consumption. So they're in better health and can therefore supply more labor, both directly, the labor productivity goes up a little bit, and you're going to have a slight increase in labor force participation rates. So this is what is adding to, therefore, leading to higher GDP per capita. Also, healthcare spending per capita goes down, so medical expenses go down just a little bit, again, because people are in slightly better health than average. And there's also a slight increase in total consumption. Yes?
I would have thought that the capital per capita could have decreased
I
from
can.
the other, sort of, I don't need so much precautionary.
Exactly. So there are two effects here now. You have the precautionary savings effect, which reduces it. You are living slightly longer, and that increases your basically retirement period. So you're saving more in anticipation of it. In addition, you have slightly higher income, and you don't have the resources to worry about. So the two positive effects just slightly outweighs the negative effect. But yeah, I was myself a little bit surprised by that one. This is a steady state to steady state comparison. If you look at the transition, it will be going down first, and then it will be increasing. What about the public finance part of it? Well, government spending to GDP obviously has to go up. It is calibrated in the benchmark to be at 20%. It goes up by 4.5 percentage points because now it's financing universal health insurance. So most of this, again, is because of the healthcare spending goes up. There's also a slight increase in social security spending because people live longer, so the government has to spend slightly more on that. And lastly, what if you just do a welfare comparison? So if you ask an unborn individual behind the veil of ignorance, how much would you be willing to pay in the benchmark economy to be indifferent between that world and the world with universal health insurance? So it's a steady state analysis. I find that welfare goes up by 1.82%. So what this means is that the universal health insurance reform it wins on every front if you do a steady state to steady state comparison. There are definitely losses along the transition path. And of course, if you look at the ex post welfare implications, higher income individuals versus lower income individuals will obviously be in strong disagreement about the welfare effects of this reform. Let me just skip the Medicaid reforms. It is the same qualitatively in terms of life expectancy. But as I told you in the beginning, they have worse implications for the macroeconomy because you're discouraging labor supply, because you have this fixed eligibility criteria. So people are trying to bump around that point. So this is a standard effects that it will be discouraging labor supply. So then you have to trade off health effects with macroeconomic effects. And similarly, if you do some tax reforms, if you go to a more progressive income tax reform, basically that means that you're now redistributing from higher income individuals to lower income individuals. Again, that will have positive implications for health. Average life expectancy goes up and life expectancy inequality goes down. In contrast, if you do a proportional income tax, so everybody pays the same marginal tax rate, that makes it less progressive. Then you're going to have lower average life expectancy and higher life expectancy inequality. So what this suggests is that the more progressive the income tax code, the better the average health outcomes will be in the economy in terms of average life expectancy and life expectancy inequality, where you have always the flip side when it comes to the macroeconomy. The more progressive the tax code is, the worse it is for the macroeconomy because it is very distortionary, especially among people at the top of the income distribution. Whereas if you go to a proportional tax schedule, think about this as less progressive, standard public finance will tell you it will lead to higher GDP per capita because of more incentives to work. All right, so out of time, I'm just going to conclude. So what I've done in this paper is that I've developed a structural life cycle model with incomplete markets, heterogeneous agents, and endogenous health, where health affects longevity, medical expenditure risk, and earnings, and health evolves endogenously depending on the healthiness of your consumption basket. I then calibrated my model to match observed heterogeneity in health by income by constructing a Frailty index, which is an objective measure of health. And I used an indirect inference approach to calibrate the coefficients of the health transition matrix. Then I ran some reforms using my model, and I found that a universal health insurance reforms lead to higher average life expectancy, a lower life expectancy inequality, and higher GDP per capita. Whereas an expansion of Medicaid or an increase in income tax progressivity will lead to higher average life expectancy and lower life expectancy inequality, but it will have negative implications for the macro economy. So, thank you very much. Any final questions?
We can do two more questions and then to talk with him.
Was it a question of quality? You know, Gary Becker used always to make this argument against
quality of healthcare, you mean?
Yeah, Becker would say, well, if you have a universal system, the allocation of resources is so distorted that you're going to have an effect on quality. Quality is not to go down.
I mean, you can so different ways of measuring quality. You can think about waiting times, for example. like, do the average waiting time in the United States conditional on having health insurance versus average waiting time in Norway, where I'm from, or average waiting time in Canada. Obviously, there are going to be differences. So if average waiting time correlates with, let's say, higher mortality risk, etc., then yes, that will be an additional reason why, an additional effect that will push against universal health insurance. So yeah, like it's
investments. You would also you would say, well, you have, you know, investments will be lower in the private sector. So
absolutely.
growth in technology so that could be affected.
No, I agree completely. It's all about, I think you can do a lot of on the IO side, almost separate from this model. So if you can figure out a way of estimating what the quality implications, etc., will be of various reforms, then I could build that in exogenously in the model, and then at least would have one extra effect.
I do think it'd be good for people to see how bad the US is in terms of life expectancy, so as to change a bit their priors maybe. So you could show them how it's really flattened out, the rest of the world has gone up, because I think people have some...
Yeah, I mean, like life expectancy, and average life expectancy in the United States has been going down now for the last couple of years. There was a recent report that came out that it's very, very
But the
dark.
gap has been increasing for...
The gap has been increasing by 2.1 years over the last 15 years.
Yeah.
In Canada, for example, it's flattened out. So there's a gap, I can't remember exactly the magnitude, but that gap has at least been constant for the last 15, 20 years, whereas in the United States it's been continuously increasing.
The price of the ex goods are constant. So if you increase the demand, perhaps the price can go up. And then at the end,
yeah,
the impact on the inequality are not the same.
You're thinking that this P part there, the relative price? Yeah. So this is, it's true. I calibrate that in the benchmark economy. So yeah, if I could do if I'm just endogenizing production function, I have that as an endogenous object. Yeah, I haven't done that.
Okay, then we can continue, but we make a quick break.
Thank you very much.